Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's March 2018 issue. There are 4 articles this month that have been selected as our Editor's Choice or Highlight articles. Our Editor's Choice is a special article that analyzes the basis for the current opioid crisis in the United States. It is authored by Dr. Teresa Romans and colleagues from Mayo Clinic in Rochester, Minnesota and Jacksonville, Florida. Based on data from the Morbidity Mortality Weekly Report and the CDC, the authors point out that between 1999 and 2014, drug overdose deaths have nearly tripled, and that in 2016, more than 60,000 people died from drug overdoses, with opioids responsible for most of these deaths. And for the very first time since 1999, life expectancy decreased for U.S. citizens, and opioid overdose contributed to this decline in life expectancy. In the past, opioids were prescribed mainly for acute pain. There was no evidence to support wider prescribing practices, and there was the concern for opioid addiction and for state board disciplinary action for more liberal use. Dr. Romans and her colleagues delineates the following factors as key ones in leading up to the current opioid crisis. First, a one-paragraph letter to the editors in the New England Journal of Medicine in 1980 challenged such restricted use of opioids. The authors of the letter stated that, on retrospective analysis, addiction occurred in only 4 of 11,882 patients for whom opioids were prescribed. Second, this letter was widely referenced in support of using opioids for chronic pain, and it ushered in the broader use of opioids for pain in general and not just for acute pain. Third, many states subsequently passed the Intractable Pain Acts, which removed sanctions for long-term opioid prescription. And fourth, OxyContin was introduced and vigorously marketed for the treatment of chronic pain. The fifth and dominant factor identified by Dr. Romans and colleagues was the linkage of reimbursement for medical care to patients' perception of pain control. In 2001, for example, the Joint Commission advocated that pain should be monitored similarly to other vital signs, making pain the 5th vital sign. In addition, Congress directed the Center for Medicare and Medicaid Services and the Agency for Healthcare Research and Quality to create the Hospital Consumer of Healthcare Providers and Systems Survey that incorporated patient satisfaction data, including how well their pain was controlled. In 2010, patient satisfaction was expanded as a payment incentive by including these survey scores as part of the hospital value-based purchasing program. In attempting to achieve high patient satisfaction scores, prescription of opioids continued to escalate, with an attendant increase in dependency. Patients then sought more in the form of opioid prescriptions from their providers or illegal sources. In time, illegal, unregulated sources of opioids became a strong driver of the enveloping opioid misuse, and these sources now substantially contribute to the increasing death rate from opioid overdoses. Dr. Romans and colleagues succinctly encapsulate the opioid crisis as good intentions contributing to bad outcomes. They conclude that stopping the opioid crisis will require the engagement of all, including healthcare providers, hospitals, the pharmaceutical industry, and state government agencies, and the authors outline specific steps how such an engagement may occur. This article is accompanied by an editorial by Drs. Benjamin Shrivastava and Mark Gold from Washington University in St. Louis School of Medicine, Department of Psychiatry. These authors note that in addition to targeting the supply side of the crisis, there is also the complementary need to target the demand side of opioid use, namely implementation of preventative measures, educating physicians and requiring physicians continuing education for opioid prescribing licensure, addressing why patients use opioids in the first place, and an encompassing continuum care approach which views addiction as a chronic relapsing disease. Our first highlight article is an original article that evaluated trends in the incidence of kidney and bladder stones over 3 decades. It is authored by Dr. Wan Gam Kitana Mangkalchai and colleagues from Mayo Clinic, Rochester, Minnesota, and Indiana University Health Physicians, Indianapolis, Indiana. Previous studies have relied on diagnostic codes or survey questions to identify patient populations with kidney or bladder stones. The present study analyzed adult first-time stone formers residing in Olmsted County, Minnesota, who first presented for medical care between January 1, 1984 and December 31, 2012. This patient population was validated and characterized by age, sex, stone composition, and imaging by computed tomography so as to clarify whether any changes in the incidence of kidney stones were due to improved diagnostic approaches or reflected a true increase in the incidence of stone formation. During this period, there were 3,224 confirmed symptomatic kidney stone events, 606 suspected symptomatic kidney stone events, that is, no stone was seen, 617 asymptomatic kidney stones incidentally detected, and 181 bladder stones. The incidence of confirmed symptomatic kidney stones substantially increased from 1984 to 2012 in both men and women, with the largest absolute increase occurring in younger women. The incidence of suspected symptomatic kidney stones did not change, but that of asymptomatic kidney stones increased over the time period. Utilization of CT scanning for confirmed symptomatic stones increased from approximately 2% in 1984 to 77% in 2012, and there was a corresponding higher increase incidence of symptomatic small stones, namely equal to or less than 3 millimeters in size, as compared with larger stones. The incidence of symptomatic kidney stones with documented spontaneous passage increased, while the incidence of kidney stones with unknown composition increased more than those with known composition. The authors conclude that the incidence of symptomatic and asymptomatic kidney stones increased dramatically from 1984 to 2012, and that the increased utilization of CT scanning may have improved stone detection and contributed to the increased kidney stone incidence. The second highlight article is an original article that examined immunohistochemical staining, semi-quantitative scoring, and survival analysis in 5,263 patients participating in the Ovarian Tumor Tissue Analysis Consortium. It is authored by Dr. Matthew Block and colleagues from Mayo Clinic and multiple international centers. Epithelial ovarian cancer is the 5th leading cause of cancer death among women in the United States, resulting in more than 14,000 estimated deaths in 2017. Less than 40% of patients with epithelial ovarian cancer are cured, as more than 70% of patients are diagnosed with advanced disease. This analysis of epithelial ovarian cancer involved a patient population 10 times greater than the previous population studied by this group. This study focused on the significance of 3 potential prognostic factors: histiotype and survival. The prognostic factors evaluated were tumor expression of myeloid differentiation primary response gene 88, MYD88, tumor expression of toll-like receptor 4, TLR4, and a combination of these 2 markers. Patients were diagnosed between January 1, 1978 and December 31, 2014, including 2,865 higher-grade serous ovarian carcinomas with more than 12,000 person-years of follow-up time. Most cancers were advanced and high-grade, and more than half of the patients were deceased at the last follow-up. Women with high-grade serous ovarian carcinoma and strong MYD88 expression had slightly poorer survival than those with weak expression. There was no evidence of a survival association with mid-88 expression for women with endometrioid ovarian carcinoma, clear cell ovarian carcinoma, and mucinous ovarian carcinoma. Women with low-grade serous ovarian carcinoma and strong mid-88 expression had marginally better survival outcomes than those with weak mid-88 expression. This study supports an association between increased mid-88 expression and poor survival in high-grade serous ovarian carcinoma, and demonstrates that increased mid-88 expression is also associated with advanced stage high-grade serous ovarian carcinoma. In addition, the study indicates that both mid-88 expression and TLR4 expression are associated with favorable survival in low-grade serous ovarian carcinoma. This study thus highlights the significance of these molecular markers with regards to survival in ovarian cancer and the biologic differences between the two serous histotypes of ovarian cancer. The third highlight is a brief report comparing smoking and elevated serum erythropoietin levels, the latter widely considered as the cause for smoking-induced erythrocytosis. It is authored by Dr. Michel Eisenga and colleagues from the University of Groningen and the University of Utrecht in the Netherlands. The authors analyzed data from the Prevention of Renal and Vascular End-Stage Disease PREVENT study, a prospective population-based cohort of Dutch men and women aged 28 to 75 years. In total, 8,592 subjects constitute the PREVENT study at baseline. All participants completed a self-administered questionnaire regarding demographics, cardiovascular and renal disease history, smoking habits, alcohol consumption, and medication use. Smoking status was categorized as never, former, and current, less than 6 cigarettes, between 6 to 20, and greater than 20 cigarettes per day. Smoking less than 6 cigarettes per day compared to non-smoking was not associated with hematocrit, hemoglobin, or elevated serum erythropoietin, but was associated with mean corpuscular volume. Both smoking 6 to 20 cigarettes and smoking more than 20 cigarettes per day were positively associated with hematocrit, hemoglobin, mean corpuscular volume, and inversely with elevated serum erythropoietin. A dose-dependent effect was not observed. The authors identified an inverse association between smoking and serum erythropoietin levels, which is contrary to the common belief that smoking-induced erythrocytosis, the most common cause of secondary erythrocytosis, reflects elevated serum erythropoietin levels. The basis for smoking-induced erythrocytosis is thus unresolved and merits further investigation. Additionally, further studies should determine whether elevated serum erythropoietin levels occur in smokers at other times during the day. As always, you can access these highlights and editor's choice articles free of charge during the entire month of March when you visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org. You'll find other free content. You could also find links to our social media by clicking the buttons at the top of the home page to follow us on Facebook, Twitter, and YouTube. Our website lists many news stories that are based on articles published in Mayo Clinic Proceedings. You can also check out our YouTube channel, where you'll find other authors' interviews, 60-second video article summaries, and our Mayo Clinic Proceedings fireside chat recordings, which is available from our website on the home page as well as through iTunes. And as always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.